Hello all, in today's video, I am going to speak about protein energy malnutrition. Protein energy malnutrition is a common medical condition in children caused by a serious deficiency of energy, protein, and micronutrients which is necessary for the body. Energy malnutrition can be manifested as underweight, stunting, wasting, and edema. Protein energy malnutrition is primarily a problem in resource limited countries. Worldwide, PEM is a leading cause of death in children under the age of 5, with the highest prevalence in Africa and Southeast Asia. What is protein energy malnutrition? Protein energy malnutrition, PEM, is a deficiency disease caused in the infants due to food gap between the intake and requirement. It affects children under 5, mostly belonging to the poor, underprivileged communities. PEM is particularly serious during the post-weaning stage and is often associated with infection. The term PEM covers a wide spectrum of clinical stages ranging from severe forms like kwashiorkor and marasmus to the milder forms in which the main detectable manifestation is growth retardation. Now, coming to the etiology of PEM, there are various factors contributing to protein energy malnutrition. First one is diet, second is socio-economic factors, third is environmental factors, fourth is biological factors, fifth one is role of free radicals and aflatoxins. Now let us see in detail about the diet. There are many causes which contribute to PEM. A diet which is deficit in protein and energy or calories result in PEM. Though prolonged breastfeeding of children should be the rule, the amount of breast milk secreted in poor Indian mother is lower. Next, coming to socio-economical factors, poverty is one of the major causes of protein energy malnutrition, which leads to low food availability and unsanitary living condition, which is the root cause infection and other diseases. Next is improper distribution of food among the family members. Improper childcare, neglect, etc. may also lead to PEM. Misconceptions about foods, poor child rearing practices, and lack of knowledge may all lead to PEM. Next is the environmental factors. Overcrowding of living space, along with unsanitary living conditions, led to frequent infections like diarrhea, flu. Respiratory infection and diarrhea are the common diseases that cause severe PEM and death. Next is the biological factor. Maternal malnutrition before and during pregnancy may already make the child vulnerable to undernutrition, and proper care and nutrition, if not provided post-birth, may cause PEM. Infectious diseases are major contributing cause of PEM. Diarrheal diseases, measles, respiratory, and other infections decrease body's immunity. Lack of adequate nutrition further hinders the nutritional status. Role of free radicals and aflatoxins. Free oxygen radicals potentially are toxic to cell membranes and are produced in the body during infections. These free radicals are not combated well when the diet of the child is deficient in vitamin A, C, and E. That's the reason accumulation of toxic free radicals and aflatoxins in the body, which harm the liver cells and may cause kwashiorkor. Next is diagnosis of PEM. Protein energy malnutrition diagnosis relies on combination of clinical assessment, including history, physical examination with anthropometric measurements like height, weight, and BMI, and potentially laboratory tests to assess breakdown and albumin levels. Here is a more detailed breakdown. First one is anthropometry measurement assessment, which includes weight, height, body mass index, mid-upper arm circumference. Next comes the biochemical assessment. And the first one is serum albumin. Next one is complete profile. And the third one is liver function test. And the clinical examination is done to check whether the child has muscle wasting, edema, skin changes, hair changes, and other signs like fatigue, weakness, irritability, and apathy. Diet history is done to find out the meal pattern, 24-year recall, and food frequency questionnaire. Now, coming to the diagnostic criteria and tools. And finally, we also do functional status assessment, assess functional abilities such as grip strength as a measure of overall health and nutritional status. Next is the diagnostic criteria and tools. According to GLIM, that is Global Leadership Initiative on Malnutrition, this framework uses a combination of phenotypic, that is observable, and etiological, underlying cause criteria to diagnose malnutrition. The phenotypic criteria include weight loss, low BMI, and reduced muscle mass. Whereas the etiological criteria includes reduced food intake or absorption and increased disease burden or inflammation. The second tool is designed by Academy of Nutrition and Dietetics and American Society for Parenteral and Enteral Nutrition. This framework focuses on 6 malnutrition indicators: unintentional weight loss, reduced intake, muscle wasting, fat loss, reduced hand grip strength, and reduced functional status. According to the Indian Academy of Pediatrics, the classification is also based on weight for age, but the cutoff level to separate the malnourished children is 80% of the standard. So, the grade 1, if it is grade 1 malnutrition, the child will be 71 to 80% of the standard body weight. Grade 2, 61 to 70% of the standard weight. Severely malnourished children are classified into grade 3 and grade 4, and the percentage weight is 50 to 60% for grade 3, and for grade 5 it is below 50% of the standard weight. Now, coming to the classifications of PEM, protein energy malnutrition is classically described as one of two syndromes, marasmus and kwashiorkor, depending on the presence or absence of edema. Each type may be classified as acute or chronic. Additionally, marasmus can precede kwashiorkor. Many patients exhibit symptoms of both disease states. Marasmus or PEM without edema is defined as inadequate intake of all nutrients, especially calories. Its extreme form is characterized by muscle wasting and depletion of body fat stores. Other findings may include hypothermia, bradycardia, hypotension, decreased metabolic rate, loss of skin turgor, and constipation. Kwashiorkor or PEM with edema is characterized by muscle atrophy, maintenance or gain of body weight, and peripheral edema. Other characteristics include adasarca, that is generalized edema, hepatomegaly, enlargement of the liver, dry and peeling skin, anorexia, hypothermia, and apathy. So what is marasmus kwashiorkor? Marasmus kwashiorkor is the third form of PEM, where the child displays the symptoms of both marasmus and kwashiorkor. The symptoms of marasmic kwashiorkor include signs of both conditions like muscle wasting, edema, along with hair and skin changes. There is the presence of moderate anemia along with vitamin deficiencies. Now let's discuss about the metabolic changes that occur in the body during protein energy malnutrition. First one is carbohydrate. Fasting blood levels are low. Severe hypoglycemia is seen. the glycogen stores are depleted, led to fluctuation in the blood sugar level, and the rate of gluconeogenesis is altered. Protein metabolism, the serum concentration of total protein is decreased. Infections may lead to increased concentration of globulins, altering the albumin-globulin ratio. Total serum amino acid is reduced, particularly the branch chain amino acid. Serum concentration of many enzymes are reduced, which reflects the low rate of protein synthesis. Fat metabolism, varying degree of fat malabsorption is seen in a child with kwashiorkor. There is a reduction in the activity of pancreatic enzyme lipase. In kwashiorkor, plasma levels of free fatty acid are raised, while the levels of triglycerides, phospholipids, and cholesterol are reduced. There is a decrease in the concentration of conjugated bile acids. Now coming to the treatment plan. The World Health Organization has developed guidelines to help prevent these complications and to establish a transition to normalcy. Treatment consists of 3 phases, that is stabilization phase, rehabilitation phase, and a follow-up phase. The initial stabilization phase proceeds from day 1 to 7. It consists of treatment and prevention of hypoglycemia, hypothermia, dehydration, and infection. Also, the correction of electrolyte imbalance and micronutrient deficiencies, and a cautious feeding regimen. So, this is done for the first 1 to 7 days. Next is the rehabilitation phase for 2 to 6 weeks and consists of achievement of catch-up growth, provision of sensory stimulation, and emotional support. Follow-up phase is necessary as some patients relapse. Provision of nutrient supplements is recommended for all ages affected by PM to prevent malnutrition from reoccurring. Furthermore, education on the benefits of breastfeeding and hygiene have also been found to be helpful interventions in the pediatric population. Now coming to the medical nutrition therapy, goal weight should be considered individually for each patient and is not always the ideal body weight. Enteral nutrition is strongly recommended over parenteral nutrition. Liquid nutrition supplements or high calorie and protein drinks fortified with vitamins and minerals. They can have an intact protein or can be hydrolyzed or can also be food based. LNS do not replace therapy for micronutrient deficiencies. Now coming to the nutrition and feeding plan for both inpatient and outpatient settings, the approximate energy needs based on the age. First one is preterm. So if the child is born preterm, the energy requirement will be 110 to 130 calories per kg of body weight. If it is 0 to 6 months, if the child is 0 to 6 months, it is 9 to 120 kilocalories per kg of body weight. 7 to 12 months, 9 to 120 kilocalorie of body weight. First 3 years, it is 75 to 100 kilocalories. Whereas for 4 to 6 years, it is 65 to 90 kilocalories. The energy requirement is 75 to 100 kilocalories during the first 3 years because growth spurt occurs during the first 3 years of life. Now the nutrition and feeding plan for infants, that is for 0 to 12 months. Breast milk or infant formula can be given to the child. If the patient has a volume tolerance issue, consider concentrating feeds up to 24 kilocalorie per ounce. Ensure fortification occurs with infant formula. If the patient is breastfeeding, assess adequacy of maternal milk supply through pumping history and pre and postprandial weight. For infants greater than 6 months old, include complementary food that is high in calorie and protein. Schedule recommend feedings every 2 to 3 hours. Limit total oral feeding time to 30 minutes maximum. The need for night feeding needs to be decided on a case by case basis, and it depends upon the patient's age, feeding method, whether it is a breast formula, and the risk of hypoglycemia. Feeding environment, feed in a calm, supportive position. If patient experiences reflex, keep the patient upright after the feed for 15 to 30 minutes. Ensure the environment is distraction free. So these are the guidelines for feeding the infant of 0 to 12 months. Next is for the children from 12 to 59 months, that is 1 to 5 years. The child starts eating solid foods after 1 year, and it has to chew the food and eat. So the diet of appropriate texture should be recommended to the child. Then recommend a very varied diet with foods from a variety of food groups like cereals, pulses, milk, oils, fats, nuts. All this should be included. Provide LNS in addition to meals, snacks if patient is not able to consume sufficient calories in meal or snack time. Meal planning, 4 to 5 hands of food, that is child's hand. You have to serve 4 to 5 hands of food from different food groups plus 2 to 3 ounces of nutritious drink. It can be milk, appropriate milk alternative, or an oral supplement from a cup. Next, schedule snacks, 2 to 3 hands of food plus nutrition drink in a cup. This should be the snack intake of the child. The children need to eat 3 meals and 2 to 3 scheduled snacks per day. Allow 2 to 3 hours before lunch and before dinner with no snacks in between to maximize hunger at a mealtime. Limit meals to 30 minutes. Feeding environment, provide meal with the patient seated at a high chair or at a table. Avoid on-the-go meal and snacks if they are outside of the scheduled meal snack times. That is during this meal and snack time. If they are going out, should not feed on the go meals and snacks. Also ensure that the environment is distraction free. So how can PEM be prevented? Malnutrition is a multifaceted problem and a variety of measures should be taken to prevent it. Government of India has prepared National Plan of Action to bring down the plan to bring down the prevalence of moderate and severe malnutrition. The essential components of any control program are supplementary feeding, immunization, control of minor infections, promoting food security, nutrition communication, poverty alleviation, and empowerment of women. Nutrition education can help strengthen the various strategies formulated by the government for the eradication of PEM. This includes laying stress on breastfeeding and especially exclusive breastfeeding for 6 months. Mothers should be advised to give supplementary foods for 6 months based on the household foods like cereals and pulses. Oil or ghee can also be added to increase the energy density of the food. Adolescents who are the future mothers, they should be given adequate attention. Their nutrition should be ensured and the family should be educated against the false practices. Thanks for watching.